Rashpati.
Sir, some network issue, sir. I'll resolve in one.
You have some challenge.
Sir?
You have some challenge in presenting, ma?
Sir, I have some network issue, sir. I'll resolve in 1 minute, sir.
Okay. Is Dr. Kishore available here?
No, sir. Kishore is presenting paper.
Okay,
now,
okay, okay. Okay, you please re-log in, ma, if you have any problem.
How will it happen after this time?
येलो वाला कहाँ है? बता दो मैं ले आऊँ.
Rajgopal sir, good evening, sir. We have today Dr. Srinivas Pai sir and Apurusha sir.
Yeah, moment I saw Srinivas Pai and Apurva, I thought.
Good evening, sir.
Good evening. I thought I will take some rest today after 9:30.
Student is having some challenge, sir. We will allow some time.
Good evening, sir. Rajgopal, sir.
Hi, Srinivas Pai.
How are you, sir?
Just, I think yesterday we saw you.
Day before yesterday.
Day before or yesterday?
Day before. On the 9th of August.
See, his memory is like, this is that ASI Taisa.
Unfortunately, that
Yes,
candidate did not answer a single question which I asked.
Oh.
It was a total washout. I mean, those were the questions which were suggested. So same questions I have asked. I didn't go out of the script, but unfortunately, it's a very common condition which nobody reads about. That was the issue. Very commonly seen, keloid.
Rashpati.
Good evening, sir. Dr. Rajiv, sir.
Good evening. Namaskar, sir. Namaskar.
Namaskar. I went through Rajiv sir's comments for amputation in the Facebook.
Taisa. Right.
And his rather teaching in Facebook. It was so informative, so nice. Googling questions also.
Just a bit of information there.
What happened, man? Going or no? Sure, huh?
Sir, allow me some time.
Good evening, Dr. Jailal.
Good evening, sir.
Jailal sir, good evening, sir.
Good evening.
Good evening, Dr. Jailal.
Good evening, sir.
Kanakavelu gave me an opportunity to personally meet you, but somehow college does not allow, sir, NMC inspection anytime.
Yeah.
Kishore, you ready, Amma?
Now, since last
Good evening, sir. Yes, sir. Good evening, sir. Kishore, you can start your PPT, Kishore.
Yes, sir.
Friends, I'm sorry. We are little delayed. Sorry for the delay. And we have two candidates, in fact, kindly contributed by Jailal sir this evening, few hours before, because the candidates who are supposed to present had some unique challenges. So sir had to pull up these boys who are presenting in the TNS account to present in our forum. Thank you, Jailal sir. And we have two eminent faculty, Professor Apur Shah from Ahmedabad and Professor Srinivas Pai from Thyroid sir, joining us today as an invited faculty. We have Dr. Chennai sir, Dr. Sahai sir, Dr. Jailal sir, and other eminent faculty with us. So friends, today we have two cases. The first case will be a thyroid and the second one is the CA penis. Again, carefully advised by Dr. Jailal sir, so that he felt that one case should be a long case and one case should be a short case. So faculty, kindly take over. Kishore, you please introduce yourself, your unit chief, and start your presentation.
My screen visible, sir?
Yes, ma, you are good to go.
Go ahead.
Yes,
Good
sir.
luck.
Good evening. Good evening, sir. Hello. Yeah,
Yes, ma'am.
Yeah.
Good evening, sir. Today I'm going to present about a case of neck swelling. Myself, Dr. Kishore, final year postgraduate from Kanyakumari Government Medical College. I'm going to present under the guidance of Dr. Professor Jailal sir, my HOD sir, and Chief sir, Dr. K. Rajkumar sir, and my assistant professors, Ajin Manohar sir and Ajin Daniel sir. My patient is 29 years female, Steffi by name, resident of Nagarkoil, admitted with the chief complaints of swelling in front of lower part of the neck for the 2 years. Patient was asymptomatic before 2 years. Then she noticed a small swelling roughly around 2 centimeters in front of lower neck, insidious in onset, progressively increasing in size over the period of 2 years. There was no associated complaints of neck pain, weight loss, hoarseness of voice, difficulty in eating, no history of difficulty in eating, no history of weight loss, no history of loss of appetite, no history of lethargy, no history of weight gain, no history of constipation, no history of cold intolerance, no history of anxiety, no history of diarrhea, no history of excessive sweating or heat intolerance, no history of any other neck swelling, no history of radiation to the neck. And she is not a known hypertension, not a known diabetic, not a known tuberculosis patient, and no history of previous surgeries. Patient was on mixed diet with the normal sleep pattern, normal bowel and bladder habits, with no history of goitre intakes. And she attained menarche at 13 years age with regular cycles and normal flow, not associated with pain and clots. And she is married at 23 years, and she had two kids who are both were healthy. And family history, no history of similar complaints in family members. And summary of my patient, a 29 years housewife presented with painless neck swelling in front of lower part of the neck for the past 2 years, which was insidious in onset, gradually progressive with no pressure symptoms, and clinically appears to be in euthyroid status, and no other systemic symptoms. Sir, shall I proceed or wait, sir?
Proceed.
A general exam.
I don't know about the others. If they want to ask.
Yeah, please proceed.
Proceed.
Yes, sir. After taking verbal consent, I have examined the patient in proper light and exposure in the presence of female attender. Patient was conscious, cooperative, well-oriented to time and place person, fairly built and averagely nourished, BMI is 21, and no loss of weight, eyes no pallor, no eye signs, and face, no facial puffiness and no cyanosis, hands no tremors, ECG score 0, and no pallor, no cyanosis, no icterus, no clubbing, no generalized lymphadenopathy. And her vitals temperature 98.6 degrees Fahrenheit, pulse rate 84 per minute, regular in rhythm. Blood pressure 116/72 mm of Hg, measured in right arm supine position and brachial artery. Respiratory rate 14 per minute. Examination of neck. After taking verbal consent, I have examined the patient in sitting position, proper light and with exposure in the presence of female attendant. On inspection, a globular swelling of measuring 3 to 2 centimeters situated in the thyroid region towards the more of left side. Swelling moves with the deglutition, lower border visible and swelling. Swelling smooth surface and with well-defined margin. Skin over the swelling is normal. No scars, no dilated veins over the neck and upper chest. Trachea appears to be in midline. Extent of the swelling, superior border 2 centimeters from thyroid cartilage, inferior border 1 centimeters from sternal notch, lateral border anterior border is more of towards the anterior border of the left sternocleidomastoid. Medially, the swelling was crossing the midline about 1 centimeters to the right side. Right lateral border 2 centimeters medial to anterior border of right sternocleidomastoid. On palpation, patient is examined in sitting position.
Doctor, could you go back a slide, please? Could you
Yes,
just go back and tell the extent again?
Yes, sir.
Yeah.
Extent of swelling, superior border 2 centimeters from the thyroid cartilage, inferior border 1 centimeters from sternal arch, left lateral border anterior towards the anterior, more of near to the anterior border of left sternocleidomastoid, medially crossing the midline about 1 centimeters to the right side, right lateral border 2 centimeters medial to the anterior border of right sternocleidomastoid.
So this swelling is in the both the anterior triangles.
Yes, sir.
And crossing the midline.
Yes, sir.
Okay, thank you.
Do you have the picture of the patient?
Yes, sir.
Okay, fine. Continue. Then show. Continue.
A picture was added in the last slide, sir. Picture is there.
Yeah, sure. Continue.
Palpation, sir.
Yes.
On palpation, patient is examined.
Hello.
I lost his audio. Krishna? Kishore?
Yes, probably the students are there now in the conference venue only, so that may be some issue with their connection.
Hello.
I'll just call him if it is possible. என்னாச்சுப்பா கிஷோர் பிரசன்ட் பண்ணிட்டு இருந்தா கட் ஆயிடுச்சு இன்னும் முடியலையா ஓகே என்னாச்சுப்பா சரி I think it is disconnected. He is getting it connected. Another one. He has joined, no? Karthik?
Yes.
Kishore?
Yeah, he has joined.
Okay.
Am I audible, sir?
Yes, go ahead.
Yes.
Your PPT is not seen, man. Okay.
Shall I proceed, sir?
Yep.
Please.
Yes.
Yes, sir. Sorry for the inconvenience, sir. Coming to the palpation, patient is examined sitting position with the sitting position and standing behind the patient by classical method, and there is no tenderness. All inspectory findings, shape, size, surface are confirmed by palpation. Both lobes of thyroid and isthmus are enlarged with a nodular surface and well-defined palpable inferior border noted. Largest nodule measuring 4 cross 3.5 centimeters, vertically oval, palpated in the left lobe of thyroid with a well-demarcated borders, nodular in surface with a foaming consistency. Swelling moves with the deglutition. Plane of the swelling is deep to deep fascia and staph muscles. Trachea palpated in midline. Carotid pulsation felt at a normal location. No palpable thrill at superior pole of thyroid. No palpable cervical lymph nodes. On percussion over the manubrous sternum and parasternal region, there is no normal resonant note noted. On auscultation, breath sounds heard in midline on the trachea, confirming the tracheal position in midline. No audible bruit near upper pole. On systemic examination, heart sounds S1, S2 heard, no murmurs. Respiratory system normal, vascular breath sounds heard, no added sound. Central nervous CNS examination, normal mentation with intelligence, no anxiety, no tremors, no focal neurological deficits. Parabdomen soft, bowel sounds present, no organomegaly. Musculoskeletal system, no proximal myopathy, no bony pains. Examination, scalp and spine, normal. Summary. My patient is 29 years, a housewife, presented with a painless swelling in front of neck for the past 2 years, which is insidious in onset, gradually progressive, with no pressure symptoms. Clinically appears to be in euthyroid state with no other systemic symptoms. On examination, both lobes of thyroid enlarged with a nodular surface and well-defined palpable lower border. Largest nodule measuring 4 cross 3.5 centimeters, vertically oval swelling, palpated in left lobe with a nodular surface and firm in consistency. Swelling moves with a deglutition without any features of compression, fixity, retrosternal extension, and no palpable cervical lymph nodes. Provisional diagnosis: a case of bilateral asymmetrical thyroid swelling, most probably benign, non-toxic, non-malignant swelling, multinodular goiter with a dominant nodule in the left lobe of thyroid, with the patient in euthyroid status. And a differential diagnosis: colloid nodular goiter, follicular adenoma, carcinoma thyroid, thyroiditis, probably Hashimoto's thyroiditis.
Is there any entity called colloid nodular goiter? Is there any entity like that?
Colloid goiter only.
See, what is the morphological classification of goiter? Morphology. Based on the
Anatomical.
yeah,
That is asking, yes.
yeah, anatomical. Yeah.
Colloid is something histopathological diagnosis.
Morphological classification of goiter, solitary thyroid nodule will be this.
1 second.
Nodular, solitary nodular thyroid goiter.
What is MNG?
Multinodular goiter, sir.
See, the classification of goiter is colloid, is hyperplastic goiter, diffuse hyperplastic goiter, colloid goiter, then multinodular goiter.
Yes, sir.
This is the morphological classification. Okay. Solitary nodule of the thyroid is a different entity.
Yes, sir.
Can you tell us what is a solitary nodule of the thyroid?
Solitary thyroid nodule will be isolated nodule, sir. It might be on clinical it might be dominant, either dominant nodule in the background of multinodular goiter.
How do you differentiate a dominant nodule of a multinodular goiter from a solitary nodule of a goiter, solitary nodule of the thyroid in isolation?
I'll confirm with the help of clinical examination.
Clinical examination only I'm asking.
Clinical examination, sir.
I'll rephrase my question.
Yes,
in a case of a solitary nodule of the thyroid, how do you differentiate between dominant nodule of a multinodular goiter and solitary nodule in isolation? How do you differentiate the two?
With the help of trials and the Lahis method, sir.
No. What is the finding? If this finding is there, you'll tell it's a dominant nodule. If this finding is there, you'll tell it's a solitary nodule in isolation.
Thyroid gland will be palpable, sir.
In a dominant nodule, rest of the thyroid is palpable. Whereas in solitary nodule in isolation, only the nodule is palpable.
Yes, sir.
One more question I have is, in general examination, you look for the eye signs. When there was no history suggestive of any sort of hyperthyroidism. Number one. Number two,
yes,
also your pulse rate was normal.
Yes, sir. Normal, sir.
Yeah. Why the Why did you look for the eye signs?
For the completion's sake, I mentioned about eye signs.
No, does the eye sign occur without thyrotoxicosis anytime?
No, no, sir.
When does the eye sign occurs?
In the primary thyrotoxicosis, eye signs and swelling occur simultaneously at the same time.
No, in thyroid, there should be some hyperthyroidism for you to get eye signs. So when the patient is euthyroid, why did you look for them? Is it correct to look for them?
No, sir.
Yeah, common sense, right? If the patient doesn't give a history of hyperthyroidism and on physical examination, your pulse rate is normal, patient not taking any medication, then what is it is not necessary at a postgraduate level to look for an eye sign.
Yes,
in fact, not looking for an eye sign is going to help you in
Time,
scoring. Yeah.
Yes, sir.
Isn't it?
Yes, sir.
Why do you say what you examined is the thyroid? Very basic question.
Moving with the deglutition, sir.
Moving with it. So why does can you enlighten us why the thyroid moves with deglutition?
Condensation of prevertebral fascia will be Berry's ligament will attach to the base of the tongue, sir. And moving
Pretracheal. Yeah.
Berry's ligament will attach to the base of the tongue, sir. On deglutition,
Base of the tongue. Berry's ligament. Where is it attached?
Berry's ligament are attached to the thyroid cortex. Oblique line of thyroid cord.
Not attached to the thyroid cartilage. Little lower than that. It's the cricoid cartilage. So go ahead.
Right. Oblique line of cricoid.
The question is why it moves. Why the thyroid moves? We are not asking where it is attached.
On deglutition, inferior constrictor of
pharynx.
Pharynx will move upwards.
What is the relation of inferior constrictor with the cricoid? What are the inferior constrictors? Come out of the conference mode and participate in the CME mode. What is the two muscles which there? Inferior constrictor. You have a dehiscence, it can come there.
Cricopharyngeus and thyroid.
Yes, correct. So there is some relation to the cricoid with the pharynx, no? This is a cricopharyngeus.
Cricopharyngeus and thyropharyngeus.
So as they contract, the cricoid is moving up, so the contents are moving up. Go ahead.
Okay. Then, having looked at the pulse, are you able to hear?
Yes, sir.
Yeah, completely you should tell the pulse when you are telling. Just telling the rate and rhythm is not sufficient. What are the other, especially in the thyroid, to make it a habit to tell all aspects of the pulse? What all you want to tell in the pulse?
Rate, rhythm, character of the vessel wall, radio-radial delay, radio-femoral delay. Volume, sir.
Yeah.
Volume, sir.
Volume.
Volume, sir.
Yeah. Then anything else?
Rate, rhythm, character of the vessel wall, volume.
Not character of the vessel wall, character of the pulse itself. Condition of the vessel wall. Okay. These are basics. You may have forgotten these basics. In MBBS level it is. So what type of special character you will get in thyrotoxicosis?
Hyperdynamic circulation will be there.
But that is fine.
Yeah. Sir?
What is the pulse, sir, is asking? Type of pulse in hyperdynamic circulation.
Bounding pulse will be this.
What does it mean?
Volume. That's the volume.
High volume pulse will be this.
High volume pulse, but what is that special character you will get?
Water hammer.
Correct.
Water hammer.
also called as
water hammer pulse.
water hammer pulse, also called as, commonly called as collapsing pulse.
Yes.
What's the reason why the collapsing pulse is there?
Corrigens.
Because of hyperdynamic circulation.
Hyperdynamic circulation.
What is hyperdynamic circulation?
Seen due to high metabolic activity,
No, it's something to do with the blood pressure.
increased basal metabolic rate.
No, it is something to do with the blood pressure. The difference between the systolic blood pressure and the something to do with the difference between systolic blood pressure and diastolic blood pressure.
Wide pulse.
Wide pulse pressure. So what's a wide pulse pressure?
Pulse pressure.
Because your case is multinodular goiter, all these basic questions are coming. Okay.
There will be falling.
The difference between systolic and diastolic is called as pulse pressure. Okay. So to have a collapsing pulse, the pulse pressure should be less than the diastolic. Okay. If it's less than the diastolic, the difference, then you will get diastolic blood pressure should be less than the pulse pressure. Then you will get collapsing pulse.
Marked.
So never tell about the collapsing pulses there unless you measure the BP and actually do the difference.
Yes, sir. Yes.
Okay. Right. Now coming back to your case of, you said neck veins, right? You looked for neck veins.
Yes, sir.
Why did you specifically say above the chest?
Any
above the chest and above in the neck? Why did you look for dilated veins?
Any neck retrosternal extension may cause dilated neck veins.
How it causes dilated neck veins?
Narrowing of the thoracic inlet, sir.
No, that's okay. What happens when the thoracic inlet is narrowed?
There will be venous congestion.
So
superior vena cava compression.
Superior neck. So why did you specifically say neck? What is the difference between superior vena cava obstruction, where flank veins are also dilated, right? On the abdomen.
Yes.
If there is a SVC obstruction, flank veins also dilated. Am I right?
Yes, sir. Yes, sir.
So what is the difference between retrosternal goiter causing superior venical obstruction versus a superior venical obstruction where flank veins are dilated in the abdomen? You understood my question?
Yes, sir. Yes, sir.
Now, what is that level of obstruction? See, because you said neck veins and chest veins specifically, that's why I asked you the question, whether you know it. You told correctly. In a thyroid, neck vein and chest vein are only looked at. So any obstruction of the SVC above the azygous or hemiazygous system causes dilated neck veins above the manubrium sterni, in the chest and the neck.
Yes, sir.
That indirectly means retrosternal extension. You don't have to do a provocative test. What is the provocative test maneuver to diagnose a retrosternal goiter?
Pemberton test.
Pemberton's test. Okay. So tell us the pathophysiology of the Pemberton's test, the physiology behind it.
On extension, first I'll explain the patient to what I'm going to the procedure, sir, and I'll ask the patient to extend their arms and to rise above the head level. By this maneuver, thoracic inlet will be narrowed. Then patient will develop facial congestion within the span of 2 to 3 minutes. Immediately, 2 to 3 minutes, sir. Venous congestion will be there, sir.
What does this mean? Superior vena cava syndrome or superior mediastinal syndrome. Now, my question is, why did you look for this when the lower border was seen, well seen?
If the lower border is palpable,
you saw the lower border, correct? Yes. In your inspection, you clearly said the lower border. Then you told the extent also from the space of burns. You said 3 centimeters, correct? If I'm not mistaken, whichever figure. You said you gave a clear this one. Yet you looked for a retrosternal extension. Why is that?
I haven't examined. I wanted to confirm any mediastinal lymphadenopathy will be to rule out, sir.
Okay, very good. Then
But if the lower border is palpable, I don't want to go for Pemberton sign, sir. That is clinically evident and there is row on retrosternal extension, sir. If a mediastinal lymphadenopathy is there, there might be chances to develop dilated neck veins for the chest and neck parts.
Acceptable answer. Also, in any undergraduate level, it's okay not to do once you see the lower border. There are 3 reasons you may do it. One reason you are given. The second reason is there can be a ectopic goiter in addition to the goiter which is already there. The third reason is there can be a dumbbell-shaped tumor. One with the entire retrosternal and one a normal goiter. Means in the normal position.
Yes,
okay?
sir. Yes.
But this is far-fetched. Means if you are done this test, even though you've seen the lower border, then if asked why, these are the answers to escape. But they are very rare.
Yes.
Very rare
Yes,
occurrences. Okay.
Yes.
Right. You said you examined the carotid pulsations in their normal position. Correct?
Yes, sir.
So can you enlighten us what is the normal position of the carotid and which carotid did you examine?
I examined common carotid, sir. CCA, Chessignis tubercle, and the C6 transverse process.
Now, how did you measure the C6? How did you know it is the C6 tubercle?
Surface marking.
See, that is what it is. There is a lot of difference between what is theory and what is practical. Theory
But
C6. How did you count that C6?
Another upper border of the thyroid cartilage correspond to the bifurcation of the common carotid into internal and external carotid, sir.
So where exactly do you palpate? In relationship to what?
Line corresponding to upper border
Upper
thyroid
cartilage goes right up to the
carotid, sir.
Yeah. Upper border thyroid cartilage goes right up to the posterior triangle, occipital triangle.
Hello.
Where exactly you will palpate? You said normal position, no? Okay, he's gone off air again.
Am I?
He's gone off air, sir, I think.
Yeah.
Let him log in back. Anybody is calling him? Am I audible?
Yes, sir. Yes, sir.
Anybody is attempted to call the...
He's Dr. Jailal's student. I think he'll be trying if he is there.
See that question because others are listening in, so that on the YouTube. So what I was looking for is the anterior border of the sternocleidomastoid, where it meets the upper border. Yeah.
Yes, he is coming, sir.
Yeah.
Coming.
So do you have the answer, doctor?
One surface marking for common carotid artery pulse, the upper border of the thyroid corresponding to the bifurcation of common carotid into external and internal, sir, correspond to C3 level. Another border, the anterior border of sternocleidomastoid will correspond.
So where did the upper border thyroid cartilage meets the anterior border sternocleidomastoid is where I would examine for the common carotid artery. Okay. Upper border of thyroid cartilage is not the bifurcation actually. If you have seen a thyroid surgery, next time you see where the external carotid, where it bifurcates. It's pretty higher, much higher than that. Okay. You see the next time when you're seeing a thyroid surgery, you're doing it, it's higher, little higher than that. The C6 is theoretical. How do you count the vertebrae? How do you count the vertebrae? Since you said C6, no, so I want to know how will you know which is a C6 vertebrae?
Prominent posterior aspect, whatever is prominent is C2, sir. From C2, C3, C4, C5, C6, 7.
Okay. At least how many vertebrae are there in the body? I'm sorry to ask this
7
question.
plus 7. 7.
It's an answer which should come spontaneously.
Cervical 7.
No, you don't tell me cervical 7. Total vertebrae, you tell. Total vertebrae.
33, sir.
Correct. 33. Fine. Good. So, what if the carotid is absent in its normal position? It's, say, I find it in the posterior triangle instead of the anterior. Instead of the anterior triangle where I normally palpate it, let's say it's in the posterior triangle. Is it relevant? Is it important? Let us say we have
that
two.
That indicates it's a positive berry sign.
No. See, berry sign means absence of the carotid pulse. Totally. Common carotid pulse is not palpable at all. Anywhere in the neck. Suppose you are getting, and plus superficial temporal should be palpable at the same time. Okay. That means the carotid is not obstructed. Yes, intraluminal obstruction of the carotid not there. Something is surrounding the carotid. So you are unable to palpate it.
Encasement of
Encasement
of carotid sheath.
Encasement by a tumor. Maybe if it is that is the berry sign. A large goiter will shift the common carotid posteriorly. That is not berry sign. Okay. That is only shifting of the common carotid.
Yes,
what is significant is its absence.
Yes.
Also, you should feel the superficial temporal at the same time.
Superficial temporal artery sign.
Yes.
Yes.
That is berry sign. Okay. Now, you look for a bruit also, no? Why? And how did you look for it and why? You said there is no bruit and thrill on the superior pole of the thyroid. So why did you look for it?
Maybe
Hello?
Hyperthyroidism in Graves.
But your pulse rate was normal.
Bruit audible in a hyperthyroidism.
Yeah, but your pulse rate was normal, no, in this person. Your pulse rate, there was no sign. So why did you look at the superior pole? Why did you
superficial bruit? If bruit is there, it will be more audible or palpable and superficial lobe, sir. Since superficial thyroid artery is more superficial.
And most of the blood supply of the superficial thyroid
from superior thyroid artery.
Superior thyroid artery. Fine. So what's your diagnosis? Can we have a diagnosis? Can you put up that PowerPoint? Is it possible for you?
Yes, sir. Sure,
yeah.
Sir. Sure.
See, what is the issue is the clinical diagnosis is a simple multinodular goiter. You are given differential diagnosis or yes, pathology differential diagnosis. Correct? Just put it up.
Yes, sir.
Yeah. When you have a very clear-cut diagnosis, there is no necessity to give such a differential. It is controversial to give it. Okay. When you are in doubt, only you give differentials. Like in.
Yes, my slides are visible, sir.
Yes. Okay, just keep them. See, number one, colloid nodular goiter.
Yes, sir.
There is no such thing. It's a colloid goiter. You just do the literature review after this session is over. Colloid goiter. It is the second phase of a multinodular in the natural history of a multinodular goiter. Yeah, follicular adenoma. Follicular adenoma occurs in is a differential diagnosis when it's a solitary nodule of the thyroid, not in a thyroid which has multiple nodules.
Yes, sir.
Thyroiditis. Thyroiditis has pain and fever. Does your patient have pain and fever? Hashimoto's thyroiditis has transient hyperthyroidism, followed by hypothyroidism. It has a clear-cut history of pain and fever, transient hyperthyroidism, followed by permanent hypothyroidism. Okay. So without this, you can't give. Carcinoma thyroid, you have to have some clinical signs in your patient. So tell me, what are the clinical signs of of a carcinoma thyroid? When you, based on your clinical findings, you are going to offer the diagnosis of carcinoma thyroid. My answer is clear.
My patient is yes, sir. My patient is having multinodular goiter, sir. In this setting, follicular neoplasm will be more possibility of follicular neoplasm.
Listen to my question very carefully. if you have to make a diagnosis of carcinoma
Yes, sir.
thyroid, there are certain criteria in clinical examination which will make you to tell, okay, I will offer a diagnosis of carcinoma thyroid. What are those clinical findings? One by one.
On clinical examination, on history complaints, most carcinomas most of the times will be euthyroid status, sir.
Your patient is in euthyroid.
With having any voice posts, one positive.
Number one criteria is
recent change in voice, sir.
Number one, recent change in voice and history. More of pressure symptoms. Age of less than 20, more than 70. Goitres which occur in age group of less than 20, more than 70. Suspect malignancy. Okay, I've given you 3. Now you give me the rest. You heard, no? Number one.
Loss of weight and yes, sir. Loss of weight and loss of appetite.
That doesn't occur in the thyroid. See, loss of weight and loss of appetite. Loss of appetite leading to loss of weight is more of GI malignancies. They have more to do with GI malignancies.
Pressure
effects are?
Pressure effects, sir. Compressions.
More in malignancy. Then
recent changes.
Already told.
Change in voice.
Already told.
Any other mass
in
you will
swallowing
palpate?
and breathing difficulties.
No, on
lymph nodal swelling, sir.
Clinical examination.
Right? What are you going to look for? Any other swelling which can give you a hint that it could be a malignancy?
Lymph nodal swellings, sir. Palpable cervical lymph nodes.
Then something we discussed some time back.
Consistency on the swellings.
Hard inconsistency. Then.
Hard inconsistency.
Then.
So you said the classical sign is moving with moving with the deglutition. And if you have anything with that with relation to malignancy suspicion, do you have anything with the movement? Yeah.
Fixicities to the surrounding tissue.
Fixity. Then Berry's sign. You told it, no, just now. Berry's sign.
Absent carotid artery pulses.
Yeah. Then very rarely Horner's syndrome. Okay? Very rarely Horner's
pulsatile bony secondaries are more favor of follicular neoplasm, sir.
No, let's not go to that diagnosis. See, the criteria for diagnosing malignancy just based on history and clinical examination. No FNAC, no ultrasound. Number one, change in the voice. Number two, younger age group, more than 20, less than 20, more than 70, younger and older. Number three, hard thyroid. Number four, cervical group of lymph nodes, palpable. Number five, absence of carotid pulse. Number six, or very rare Horner's syndrome. Number seven, fixity of the thyroid. Okay.
Another important is in the sex of the patient. If it is a solid swelling, you are getting in a male patient, definitely it is more in chances of 48 to 50% is a chance of malignancy. So that is, if it is the same thing, it is a cystic swelling in a female, that you don't suspect malignancy more.
Yeah.
So solid swelling in a male is also indication that it could be a possibility of malignancy.
My suggestion to you is never give a differential diagnosis like this. Okay. You should have the evidence, clinical evidence to offer the diagnosis. Your diagnosis is multinodular goiter, simple multinodular goiter in euthyroid, acceptable. It is acceptable to give one diagnosis. Just in attempt, somebody has told you give more than one diagnosis. Sometimes there need not be more than one diagnosis. It is better to give one single diagnosis. Okay.
Yes, sir.
Such a patient. If you had whatever we discussed, pain, fever, and all those signs, then you can bring in all the differential diagnosis. Okay.
Postgraduate extending from one end of the benign to next end of the malignancy is not acceptable. So you have to come to some conclusion within your clinical examination, whether you are going to put it into the more of a benign etiology or a malignant etiology. You can't put both. One end you are putting as solitary tumor, another multinodular goiter. So all things you have brought in, all the four possibilities. That is, it's not a list of possibilities.
See, I disagree with sir a little bit. Most of, in principle, I agree with what he said. See, you can give benign and malignant together, but they should be very closely those findings. For you to tell carcinoma, it should have all those findings.
Yes, sir.
Okay. Sometimes change in the voice can occur with benign tumors also, benign goiters also.
Hypothyroidism, laryngeal edema.
Yeah. So now, how are you going to proceed with your patient? Let us go with your diagnosis of multinodular goiter. So, what is your aim and objective of investigation?
I'll proceed with investigation, sir. My investigation approach, confirmation of diagnosis, and diagnosis. I'll proceed with ultrasound neck as a clinical extension, and T3, T4, TSH. After that, I'll go ahead for histopathological confirmation by FNAC, sir, final aspect cytology.
So what do you expect to see in all these investigations? You are not supposed to say the least, beta. You need to tell what you are looking into. See, looking to a diagnosis, a multiple diagnosis you have put in. For example, what do you expect in an ultrasound, or what do you expect, or what do you plan to see in an FNA? And that will help you in your diagnosis.
In ultrasound, since there is a dominant nodule, I'll look for the possibility of
other people kindly close your.
Yeah, please mute everybody. Please mute. Continue.
In ultrasound, since there is a dominant nodule in the background of multinodular goiter, first of all, I look for the consistency of the nodule and echogenicity, calcifications, peripheral halo, any vascularity. I look for these signs, sir. Apart from that, lymph nodes.
Correct. And can that ultrasound help you in FNA also?
Yes, sir. Ultrasound guided FNAC obviously is a good result, sir. With the aid of ultrasound, we can take the FNAC from the solid component, so we can get the accurate histopathological finding compared to the manual FNAC, sir.
Right. What do you call the ultrasound findings in thyroid? What is that acronym known as?
Thyroid, sir.
Thyroid. Right. Well, how do you
reporting assessment and data system.
Yeah. So how do you what do you call classify according to thyroid? What do you expect? Thyroid 0, thyroid.
5 grades, sir. Hello, sir.
Yeah. Continue.
Hello. Thyroid 1 is normal, sir. Thyroid 2 benign. Thyroid 3 probably benign, sir. Thyroid 4 is suspicious of malignancy. Thyroid 5 will be highly suspicious of malignancy, sir.
Okay. Yeah. Okay. Actually, I wanted to ask you something when sir was asking. He asked you regarding normal history of any multinodular goiter. What is the pathophysiology that occurs in a multinodular goiter? The basic thing that sir was asking.
Because of circulatory constant stimulation by circulatory TSH level will cause the constant stimulation of thyroid gland by
if there is a constant stimulation, there will be only one kind of growth will be there.
That will be goiter, right?
Yes, sir.
No, why there is emergence level?
there will be necrosis followed by hyperactivity will be there, sir. That
Why?
leads to the
No,
Why?
Is it due to constant level or anything else? It's mainly due to the fluctuation in the level of TSH. And also we have a separate, the response of the cells are different to the TSH. Both, it is a level of the TSH, it's also fluctuating. The types of the cells which are responding to THS, it will respond very well, which will not respond to the THS. So there is a mixed
yes, sir.
kind of that mixogenicity is the main reason which you are going to get, not the constant TSH.
Yes, sir. Yes, sir.
Okay, why? How the stages? How it is developing?
Fluctuate.
See, Apurva sir is asking you tell the entire development, how the pathogenesis MNG is developing.
So, what is required by the
Circulate
thyroid?
because of
What element is not
TSH.
metabolized in the thyroid? What is needed? What element,
Iodine.
macro element is needed for thyroid?
Iodine, sir. Iodine, sir.
You start with that. Start with that. Use that as your starting point.
Iodine will be observed from the.
No, sir is giving
Iodine
you a
will
hint.
be observed from.
Supposing there is a little less amount of iodine, what will happen?
There will be associated TSH hyperstimulation will be there, sir.
Yes, then what will happen?
Hyperplasia of
So
the
once-
thyroid gland.
Yes, very good.
There will be
That is what you
later
see.
on fluctuation of
Yes,
TSH levels. Mixed with inactive and active globules will be there, sir. And there will be sensitivity of the follicular cells to the thyroid stimulating hormone will be increased, sir.
so no. Part of this is that with the fluctuation in the TSH levels, there will be a variable difference in the growth of the follicles. Number one.
And sensitive.
Number
Yes, sir.
two, the central, because of this again the TSH this thing, the central portion may go into the
Necrosis.
huge follicles. The central part may not receive. Yes, right, and ultimately to an extent that the central part is composed only of colloid material, and the active part in the gland becomes only the peripheral zone of each and every follicle.
Yes.
Right. Okay. Another thing I wanted to ask was regarding, you said that no family history. So what did you ask about family history? Very interesting and very important.
Men syndrome, sir.
Men तो बहुत बाद में आता है बेटा. First of, no, man
Multiple
is quite
endocrine
behind.
neoplasia.
No, that is later. First of all, we talk about the locality where he stays and
Endemic,
the other
endemic,
another disharmonigenesis.
Endemic goitre, sir.
Where do you see endemic goitres? In India, where do you see endemic goitres?
Hilly regions.
Hilly regions or something else?
Plateau of the bottom, down the
yes,
hilly
bottom
regions.
Of the hills. Yes, bottom of the
that
hills.
That water will
region.
be iodine deficient, sir.
Yes. So that is endemic area, and another important thing as far as families. See, man comes later on. Before that, we have disharmogenesis. What is the disharmogenesis? Yes, what is disharmogenesis?
Thyroid agencies.
No, disharmogenesis. There is some issue with the making of T3 and T4. Some enzyme deficiencies or something. Are you there?
Sir, yes, I am audible, sir.
Yeah. Okay.
Lag in the internet. He has a lag in the internet.
Sorry, sir.
that's
Actually,
fine.
I was in conference.
No, don't. You
That's
don't need
okay,
to be
that's
sorry about it. Yes. So what is that? Those enzyme deficiencies and all those things. What is that thing?
Thyroxine peroxide, TPO deficiencies.
Peroxidase enzyme.
Thyroxine peroxidase deficiency.
Doctor.
TPO,
Yeah.
TPO deficiency, thyroxine peroxidase.
Listen, sorry, saying something. Listen. Sorry, saying something.
Doctor, my advice to you is pick up a physiology book, basic physiology book, start reading it. Okay. Surgeries requires understanding of physiology also a little bit. Okay. Blindly don't. If you understand physiology, you'll be able to treat the patient. Okay. Now let's say on your ultrasound, you found some nodes in the neck.
Yes, sir.
Which you didn't palpate, but you found it. Now,
Yes, sir.
how do you suspect a node is malignant on a thyroids?
First of all,
What you said, thyroids includes the goiter as well as the nodes evaluation. Okay. So what tells you the nodes are malignant?
first of all, I'll look for the shape, sir. Normal
Yeah.
lymph node will be bean shaped or kidney shape. If there is a change in shape to circular, that is more goes in favor of malignant lymph node, sir. Loss of fatty hilum suggests of probably malignant node, sir.
3. Circular nodes.
Peripheral.
What about
Loss of peripheral loss of fatty hilum and peripheral halo.
that is for nodule, not for node. Lymph node, not for lymph node. Number 1 is round lymph node. Number 2 is cystic lymph node. Cystic.
Yes, sir.
If the lymph node. Number 3 is microcalcification within the nodes.
Calcium.
And last one is your loss of hilar architecture. Okay.
Yes, sir.
These also become thyroids 5 in thyroids. So thyroids don't go with the evaluation of the goiter alone. Look at the lymph node also. Okay.
Yes, sir.
So let us say you get the lymph nodes are there and they are highly suspicious of malignancy. What will be your next step?
FNAC, sir.
FNAC, you have a multinodular goiter and then you have lymph nodes. FNAC of which one?
I'll go for a FNAC from dominant nodule and ultrasound guided FNAC from dominant nodule and suspicious lymph nodes, sir.
You said follicular. How does FNA help? It will be a little confusing. Can you go elaborate further? Anything else you can do?
In case of follicular neoplasm, ideal I'll go with the right hemithyroidectomy along with the frozen section.
No.
If intraoperative frozen,
Stop.
We are not going to the treatment part, still on the diagnosis.
I am asking you. You said about FNAC. And you are talking about follicular adenoma. Can you do something else than FNAC, which is even better? Or what is the problem of FNAC in follicular adenoma?
It can't differentiate follicular adenoma and carcinoma, sir. Vascular invasion.
So what can you do? What? Not vascular, capsular. Yes. Yeah. So
67. K67 prolif.
A true cut would be a better approach. Ultrasound guided true cut biopsy would definitely give you the capsular or a frozen section at the time of surgery.
Yes, sir.
Either or would be a good approach.
Yes, sir.
Right. Okay. So
core biopsies of the thyroid, no? True cut biopsy.
Core biopsy.
Core biopsy is the terminal same thing as a true cut biopsy. It's got some risks. One is bleeding, hemorrhage. Okay.
Bleeding.
And if you take the follicular carcinoma like a clock, like a shape of a clock, okay, just for imagination. Let us say the malignancy is at 4 o'clock. Okay. Let us say you hit at 4:1. You understand what I'm saying? If you hit 4 hits at 4:1 in the clock,
yes, sir.
But your malignancy is at between 3:55 and 4 on the clock, you will miss
Yes, sir.
You will get a normal benign sample because the capsular invasion will be at 3:55 to 4 o'clock on that clock. Whereas your
Yes, sir.
core biopsy is hit at between 4:1 and 4:2. Okay.
Yes.
Number
Understood.
2, there is a risk of hemorrhage. So the benefits of a the risks of a core biopsy outweigh the benefits. You will not get an accurate diagnosis, nor will you'll have a problem of hemorrhage also. Okay.
Yes, sir. Yes, sir. Yes, sir.
It is core biopsies are done in inoperable, you need the diagnosis to give radiation or chemotherapy, like in a lymphoma, where you can't get to a biopsy, right? You're not getting accurate. That time you do a core biopsy. Okay.
Yes, sir.
So generally, core biopsies are avoided in any type of malignancy. The minimal biopsy for a thyroid is a hemithyroidectomy. The minimum biopsy for assessing a follicular carcinoma is or follicular adenoma is a hemithyroidectomy.
Yes,
okay.
Do,
You can look it
do
up.
you have any tumor markers?
Yeah.
Do you have any
K6
molecular diagnosis or a genetic diagnosis option?
K67 proliferate index gives
No, K67 is not much useful in a thyroid malignancy. Like BRCA1,
red.
for that. What is rule in and rule out genetic test?
Red.
What are the options you have? What is BRAF 400? So there is an array of genes tests are there, or called rule-in test and rule-out test. The rule-in test can give you some clue for what it whether fit into. Rule-out test, it says 7 genes or 8 genes they study, and they say that definitely it is not a malignancy. So when you are in a doubt, and before going for embarking into the hemithyroidectomy or that, and you can still, if an option is available, you can go for a molecular testing for the suspicious malaria, either FLUS or ALUS. There you can go for a genetic test, molecular testing. So how you are going to proceed now?
Yeah. And I think you have the picture of the patient. If you can just share the picture. Or anyway, what is your ultrasound finding? Have you got an ultrasound?
I had ultrasound findings. Multinodular goitre.
Multinodular goitre. Okay, then what will be doing? And multinodular goitre involving both the lobes?
Yes, sir.
Right. So now what will you do?
What kind of malignancy you will expect in a multinodular goitre?
Follicular neoplasms.
Multinodular goitre.
Long-standing multinodular.
From where the carcinoma arises?
Interfollicular.
Yes.
Interfollicular tissue.
Suppose you think it is an Hashimoto's induced multinodularity.
Papillary carcinoma will be more common in Hashimoto's thyroiditis.
Papillary and
Only is
squamous.
Yes.
And squamous cell carcinoma also. Okay. Although rare, the two carcinomas which occur, 99% papillary. No, sorry, 90% papillary. One more malignancy is there in between. Which is
thyroid lymphoma will be rare, sir.
Lymphomas. Very rarely squamous cell carcinoma. Okay.
Yes, sir. Yes, sir.
Very rare.
Sir, I told you about Hashimoto's. Can you elaborate something on the pathophysiology of Hashimoto's?
Lymphocytic infiltration of thyroid follicles will cause the initial hyperactivity and hyperthyroidism state, sir. After that, wait.
It is not hyperactivity. That is what I wanted. That's not the correct word to be used for. It is not hyperactivity. What it is?
How that it's not hyperactivity, but how that you get hyperthyroidism or increased tension hyperthyroidism?
A release of thyroxine from the thyroid follicles.
Why?
due to increased vascularity and follicular destruction,
No.
sir.
Yeah, more destruction.
No,
The word is destruction of the thyroid gland. The follicles get destroyed, the thyroid is released. Right? That is
That
why the
will not-
patient has hyperthyroidism.
Yes, sir.
So
No, when the patient-
sorry, sir. Supposing
No.
the patient of toxicosis, I mean Hashimoto's, comes to you with toxicosis, features of thyrotoxicosis, how will you differentiate it from Graves' disease?
What are the option you have to differentiate from the tension hyperthyroidism and the hyperthyrotoxicosis hyperthyroidism?
In case of hyperthyroidism, because of thyrotoxicosis, the symptoms are due to circulatory antibodies.
No, how do you differentiate? I'm asking. How do you
You are-
differentiate?
So because it is important, because when a patient with the transient hyperthyroidism, you should not give an anti-thyroid drug. If you give that, it is further worsen the condition. But in the thyrotoxicosis, you have to give, so you have to differentiate clinically.
First
And
sign-
Go ahead.
First,
Continue.
clinically, signs will be evident first, sir, in case of primary thyrotoxicosis, followed by symptoms will appear, sir.
Clinically, first
Swelling
thing
will
is that in Hashimoto's, it's a very short history as compared to Graves' disease. If we talk about clinical aspect, it is more likely to be a short duration history, more clinical pain, probably tenderness also.
Yes.
But more importantly, what investigation will separate the two?
No, you said initially about some antibodies, and is there is anything role you have in antibodies?
How are you?
Anti.
And please mute everybody. Please mute.
I think the candidates audio.
No, sir, I'm in isolated place, sir.
Okay. No,
Can
you
I give sir? Please check. A lot of noise is there. No.
Doctor,
Yes, sir.
able to hear me? Are you able to hear?
Yes, sir.
See, Hashimoto's thyroiditis, autoimmune disease.
In art,
Graves' disease also is an autoimmune disease. Correct?
anti-TPO.
Let the disturbance go away.
No, please.
Yes, sir.
Wait. Can I sir? If you are there, please check that. There's a lot of noise is there. Somebody who is there in the conference venue, please close your. Can I sir? I think your audio is making a noise. Can I sir? I think. Doctor, sir, your audio is making noise here. We're in the conference area.
Nicely. I told you 1 year we'll free. That obviously means everything.
Number one, it's nice to know conferences are going on. Post-COVID. We are happy to hear those sounds which are missing.
I think Dr. Sahai is the host. Dr. Sahai.
Sir, I think that Kanaivel sir is a host and he's not.
No.
Only his voice is coming.
Dr. Sahai was made the host, I think. I just saw for a flickering moment, Dr. Sahai was made the host.
Okay, doctor. We'll try to go through the noise.
Sir, in case of
Doctor, you able to hear?
sir, am I audible, sir?
Yes,
sir.
Yeah.
Okay.
Sir, in case of autoimmune disease, in Hashimoto's thyroid TPO antibodies, sir, thyroid peroxidase. Hello.
Yes, we are able to hear.
Yes, sir. In case of Hashimoto's thyroiditis, circulating thyroid peroxidase antibodies will measure, sir. In case of Graves, thyrotropin receptor antibodies, circulating levels of thyrotropin receptor antibodies levels will be high, sir.
Both, see, in both Hashimoto's and Graves, the same investigation is done. It is the level of the antibodies which are going to make the diagnosis, not the different antibodies. Okay.
It will present in both, but
Yes.
which is majority, 90% in the TPO is in favor of Hashimoto. More if we have a more thyroid peroxidase.
See, there is a
Other
theory.
than antibody. Yeah, go ahead, sir. Go ahead.
There's a theory that Hashimoto's thyroiditis and Graves' disease are the same disease. Only their duration is different. Okay.
Yes, sir. Yes, sir.
Hashimoto burns out. Correct. Eventually,
Yes,
it
sir.
becomes hypothyroidism.
Transient.
Primary thyroiditis also, if you manage it medically, after about 18 to 20 months, it will also burn out. It
Yes,
becomes hypothyroid. Okay.
Yes, sir. Yes, sir.
Okay, but
No,
if there is
this again, any other test you can do, any other way
Any
you can
other
confirm
test
that
is-
it is only.
yeah, what sir asked, what is that specific test which will 100% tell you that this
Nu-
is
Any imaging?
Nuclear scans are 99
नहीं,
technician.
nuclear नहीं होता है यार. What is simple?
Radion.
iodine?
Technician. Iodine 123, sir.
It's not available, freely available.
In India, it is not available.
Yeah, not freely.
Iodine 131.
Iodine, what's the difference between primary and Hashimoto?
What will
Primary-
happen with the
How
test in a Graves' disease?
How will Graves look on radioiodine uptake?
Graves in Graves there will be full gland uptake will be there, sir. Diffuse uptake of iodine.
Hot.
It is
Hot.
rapid.
Uptake is hot.
Hot nodules.
Not nodules.
Hot
Why it is a
gland.
diffuse?
Hot
Not gland.
Hot gland. The whole gland is hot.
Sorry, sir.
Whereas
Hot gland.
in Hashimoto's it will be
Like focused and localized.
No, what happened in Hashimoto? As you said, the
the
follicles are
gland is
ruptured.
destroyed.
Destroyed.
The
So
gland is
nothing
destroyed,
there.
right?
There won't
The
be any
pot has-
uptake.
So
The pot has broken.
less than normal. It won't even be warm, right? Either it will be less than warm, but
Yes, sir.
definitely not hot.
Yes, sir.
So now, what are we planning for this young lady?
These are ultrasound findings, sir. Thyroid gland mildly enlarged with the size, increased vascularity, 2.3 cross 1.8 centimeter size to hyperechoic nodule, surrounded
Not
by
a big one, not a very big nodule, not a very big gland, but it's a multinodular goiter. What are you planning?
total thyroidectomy.
Right.
Total thyroidectomy.
So what preoperative investigation you would like to do in this patient? I think we talked about only thyroid profile and ultrasound. Anything else you would like to do?
Indirect
Before the
laryngoscopy to assess vocal cord conditions before proceeding for surgery. Medial
Yes.
scope.
Anything else? Yes. Anything else?
Doctor,
T3, T4.
I'm seeing thyroiditis in your ultrasound report. The second slide. Impression, features of thyroiditis for nodules, 3 nodules. Does it change your management? No. Hello. Am I audible? Hello.
Are you hearing?
Yes, sir.
Yeah.
Yes, sir.
It's
Yes,
saying
sir.
features of thyroiditis. So does it change anything? Do you want to go ahead with total thyroidectomy?
Before that,
So
we
now-
have, I wanted to proceed for circulating thyroid antibodies, sir, TPO and
Very good.
thyrotropin receptor antibody.
Yeah, do you have them?
Actually, Yes, this patient recently we have admitted, sir, and patient she needs to be evaluated, sir.
Okay, fine. I will give you the values. They are raised. Let us say the ultrasound report and your lab investigations are concurrent, are matching with each other. Plus, you have ventured out to do an FNAC, which confirms your Hashimoto's. Now, how will you proceed?
Hashimoto's for hyper.
What is your thyroid function test? Is it gives a hypothyroidism or it gives a normal?
Patient will euthyroid states.
No, that is your clinical feature. Your lab, what does the laboratory show?
Laboratory values and euthyroid state only, sir.
Euthyroid state only. Okay, fine.
So with the 2 centimeter nodule in Hashimoto, are you interested in doing a surgery or you are going to plan for a conservative?
Conservative management.
When will you operate Hashimoto's? If at all, what are the indications of surgery in a Hashimoto's thyroiditis?
Suspicious malignancy.
No. You have done the FNAC, it has proved not a malignancy. It is, so there is no question of suspicious you are going to put there. No, you already known the clinically you examine the size. Is there is any size criteria? Is there is any
compressive symptoms and cosmetic deformities?
cosmetic? You can't decide. Compressive symptoms.
Suspicion of malignancy, sir.
Size.
Any gradual increase in the size of nodule indication for surgery, sir.
Any asymmetry. If you have an asymmetry of one of the nodules, asymmetrical increase, then if you have lymph nodes, then we have to go in for surgery. I think he has asked us to close the discussion in the chat box.
Yes, sir.
We may wind up. So tell us, MNG, for last no, MNG, what are the indications of surgery? Then MNG. Your ultrasound is wrong, I think, thyroiditis. It cannot make a diagnosis on an ultrasound, thyroiditis. It's usually a lab
clinically
lab
don't
diagnosis.
have any patient don't have any toxic symptoms, sir.
Yeah, patient doesn't have toxic symptoms.
No pain, no fever, sir.
What are the indications for surgery in a multinodular goiter?
Pressure symptoms, chronic persisting MNG, chronic long-standing MNG, sir. Multinodular goiter, cosmetic deformity, asymmetry, carcinoma. In an
MNG, multinodular goiter. Number 1 is pressure effects. Number 2 is pressure effects. Number 3 also is pressure effects. We don't operate a MNG unless there are pressure effects or suspicion of malignancy. Okay.
Yes, sir.
Yeah. In which case you can't do core biopsy and all those things. In which case you have to do a minimum hemithyroidectomy in that. Okay. So there is a school of thought that don't do hemithyroidectomy. If you are operating the thyroid, do total thyroidectomy because you don't know where it is, the malignancy. Unnecessary to come back and do one more surgery. Okay. But if you look at the textbook written by the Americans and British, they give us hemithyroidectomy. They don't say do total. Okay.
Yes,
but we for practical reasons in our country, resource constrained, we should have our own guidelines. So we do a total thyroidectomy if we are operating. Okay.
Another important thing is even so many years we have seen many huge thyroids, but they don't routinely, MNGs don't routinely come up with pressure symptoms.
Yes,
routinely you don't see. So in our setup, most of the time it is the cosmetics, more importantly, and development of any complications.
Toxicity also one of the indications. Toxicity also one of the indications.
Yes. So that is the more of an indication, right? And as I already said that most of the time MNGs, especially in an MNG, we always almost go for either near total or total thyroidectomy.
Yes, sir.
Okay.
Yeah, can I sir, we can close this case and you can go for next case.
Can we start with another one?
Yes. Thank you, Kishore, because we have disturbed him in the midst of the conference and at 5 o'clock and asked him to present the case. Probably he had
Yes,
no
sir.
time to review his anything. But okay.
Krish, do you have any questions, Krish?
Sir, only one question, sir.
Sorry, ma?
One question, sir.
Yeah.
Is any
Go ahead.
there is any role of immunohistochemistry in case of thyroid malignancy, sir?
No. Unless you suspect sarcoma, which is very rare in thyroid. Otherwise, ISC is not required.
Yes, sir.
We don't routinely do it. Okay. Even
Yes,
the
sir.
tumor markers, except the red proto-oncogene, okay, the calcitonin.
Yes.
Sorry, not the red
Yes,
proto-oncogene workup, calcitonin levels we are doing. Okay.
Yes, sir.
Especially when you are thinking in terms of medullary thyroid. Medullary thyroid.
And when we do thyroid surgery, when we do for malignancy thyroid surgery, that time we follow up by thyroglobulin, the papillary carcinoma, thyroglobulin levels we do. Okay. IHC may be available for thyroid, but it is an overkill. I wouldn't waste my money on an IHC profile. Unless it's not going to help. Yeah.
Kishore,
If your HPRA shows that already carcinoma, then probably there is no need to go over to the IHC studies.
Yes, sir. Yes.
If you have difficulty in differentiating carcinoma from the sarcoma, then probably there is a need for a immunohistochemistry.
Yes, sir. Yes. Yes, sir.
Kishore, by and large, flow cytometry remains the procedure of choice. Immunohistochemistry is slowly getting out of use. So
Yes,
it is more specific than immunohistochemistry, especially FNA, liquid cytology, all those things are fundamentally cell-based. So things are moving from IHC to flow cytometry.
Yes, sir. Yes, sir.
Okay. Faculty, can we move to the next case? Thank you, Dr. Kishore, for presenting in such a short notice. Thank you, Jailal sir.
Yes, sir. Thank you, Kanagvel sir, and my HOD sir, Jailal sir, giving this opportunity to present in this forum. Thank you very much, sir.
And now I call Dr. Ashwati to start a presentation on the growth thinness. Dr. Ashwati, please introduce yourself, then introduce your chief, and then HOD, then start your presentation.
This is a short case, right?
Go to the first slide, Kana.
Sir, that depends upon how you make it, sir. Apurva, sir. You can make it short and long.
It can be long also.
Good evening, sir.
Go ahead, Ashwati.
Make it full screen, ma.
Good evening, sir. Good evening, sir.
Yes, ma. Good luck to you. All the best. Faculty, please take over.
I'm Dr. Ashwati, final year postgraduate, Kanyakumari Government Medical College. My HOD is Dr. Jailal, MSFRCS, and my unit chief is Dr. Angel Vincent, my assistant professor Dr. Arul Kumar and Dr. Arul Kumar. Shall I proceed, sir?
Please go ahead.
Yeah, please.
I'm presenting case of a 60-year-old.
Your voice is disturbed, huh?
Hello, beta, we cannot hear you.
Ashwati, you are not audible.
Sir, one second.
Please go back. You are not audible.
Hello, sir. Am I audible, sir?
Yeah.
Yes, yes.
Sir, I'm proceeding, sir.
Yeah.
Hello.
Go ahead. Go
History
ahead.
of presenting illness. Patient notices swelling over the distal end of the penis, which was insidious in onset, gradually progressing and not associated with any pain. Associated with foul-smelling purulent discharge, which is scanty in amount, and occasionally patient noticed blood stain in the discharge. Patient also complains of history of inability to retract the foreskin for the past 4 months. There is no history of pain, no trauma, no history of any bowel or bladder disturbances, no history of fever, no history of any other swellings or ulcers in the groin, no history of any weight loss, loss of weight or loss of appetite, no history of cough, hemoptysis, dyspnea, no history of jaundice, no history of bone pain. And the past history, patient not a known case of type 2 diabetes, hypertension, bronchial asthma, coronary artery disease or seizures. No history of any surgical history in the past. And personal history, the only positive personal history, patient was a smoker for past 35 years. There is no history of any multiple sexual partners. The summary of my history, a 60-year-old gentleman who came with chief complaints of swelling at the tip of the penis for past 6 months, which was insidious in onset, gradually progressing, and associated foul-smelling discharge, which was occasionally blood-stained, along with inability to retract the foreskin for the past 4 months, with no other post-history. On general examination, after obtaining proper consent in the presence of a male chairperson, patient examined in the well-lit room with patient exposed from mid-chest to mid-thigh level. On examination, patient conscious, oriented, afebrile, moderately built and nourished. No pallor, cyanosis, icterus, clubbing, period edema, generalized lymphadenopathy. ECOG score was 0. Vitals, pulse rate 70 per minute, and blood pressure 110 per 80 mmHg in the right arm in sitting posture. On examination of inguinal-scrotal region, on inspection, an ulceroproliferative growth of size 4 × 3 cm in the distal end of the penis, involving dorsal aspect of the glans penis, extending 1 cm both distally from the coronal sulcus, irregular in shape, irregular margins, everted edges, on floor there was slough, external urethral meatus was normal. Bilateral visible, no other swelling visible in the bilateral inguinal region. It's an inspective photograph, sir. And on palpation, inspective findings of size and extent confirmed. Sir, can I proceed, sir?
Yeah, go ahead.
Yeah. Continue.
With irregular margins, which bleeds and also bleeds on touch. With induration not extending beyond the ulcer margin, and no stricture urethra palpable. Bilateral scrotum and testis cord structures palpable normally. The palpation of equal. On palpation of inguinal region, a firm, non-tender, mobile node of size 1 × 1.5 × 1.5 cm palpable in the right inguinal region. Opposite side of inguinal region, no nodes were palpable. Other system examination was normal. In perabdominal, there was no organomegaly. No external iliac lymph nodes were palpable. On parietal examination, anal tone was normal. And no fecal stain present. No other masks were palpable. From the history and examination, my finding diagnosis is a case of penile malignancy, most probably case of penile malignancy with clinical PNM staging T1, N1, N0, stage 3 years.
You said the skin was not retractile. I mean, is it that the skin was not retractile followed by the swelling, or was it that he saw swelling after which that the skin was not retractile?
Patient was the swelling, sir, followed by which the patient cannot retract the swelling.
So almost since 4 months he is having the swelling, right?
Yes, sir. For 6 months he is having swelling, and for the past 4 months he is having inability to retract the foreskin.
Oh, since 6 months. So he was having the swelling. He was able to see the swelling. He did not come, and then there was this inability to retract was later on. Oh, that is great. Okay. Secondly, you said regarding the coronal sulcus, it is 1.5 centimeter beyond the coronal sulcus. Or I think from what you are showing me the picture, I think even the coronal sulcus is involved. This is what I feel.
Yes, sir.
But
Yes,
in
sir.
your
Both
slide, you
proximally and
the
once
issue
an
is.
inter.
Sorry, I didn't get you.
Yeah, the swelling was extending. The ulcerative lesion was extending. One
Actually, you just
proximally.
change the photo because this should not be there in the YouTube for a long time.
Okay.
Yeah. Remove the photograph, beta. Remove the photograph. He is right. Sir is right. Fine. We can even skip the things anyway. No. Skip it.
Okay. You can close down the presentation and you can further share.
Okay.
So, to me, it looks like malignancy. That is fine. No ifs and buts about it. So, what are the pre-malignant conditions that you know about when it comes to CA penile, and how does circumcision help?
The pre-malignant conditions are chronic belnoposthitis is a pre-malignant condition, sir. Other conditions are lichen planus, lichen sclerosis, lichen planus. Erythroplakia of Curat, Bowen's disease, chronic trauma.
So what do you mean by Bowen's disease and what is mean by erythroplasia of Curat?
Both are carcinoma in situ, sir. In shaft of penis, it's called Bowen's disease, sir. In the glands, it is erythroplakia of Curat. Both are carcinoma in situ.
How it differs from Paget's disease? So the Paget's disease and this is same or different? So all three are cutaneous manifestation of underlying malignancy, but Paget's disease is from adenocarcinoma. Bowen's and erythroplasia always from the squamous cell carcinoma.
Okay.
What is extramammary Paget's disease? What do you mean by extramammary Paget's disease? Where do you get extramammary Paget's disease? So that's the one possibility. You can get extramammary Paget's penis from arising from
apocrine sweat glands.
Sweat glands. So what other glands you have in penis?
Tyson's
What are the
gland.
glands you?
Litton's gland and Tyson.
What is the function of Litton's gland?
Providing lubrication, smegma production.
It helps in the smegma. Tyson is a periurethral gland, so it helps in the urethral. So these are you can get extramammary. What is the Bowen's disease? Commonest site is not shaft of the penis. You can get in any part, but if it is coming in the shaft of the penis, it is there. So you said something. The induration is not crossing beyond the ulcer.
Yes, sir.
Why do you are interested on that? Looking for the induration.
Induration denoting the micro invasions, sir. So when we are giving clearance during surgery, we are considering the indurations and not the ulcer.
You said in the examination, you look for the stricture of the urethra. What is the interest of you to look for the stricture of the urethra?
In stage T3 and T4, there can be urethral involvements.
So is it common for a carcinoma penis to have a urethral
no, sir, it's not
involvement
common.
and urethral stricture?
No, sir, it's not common, sir. It's
So how do you examine for urethral stricture? How do you make out it's a urethral stricture or not? When you are clinical examination, where do you look for urethral stricture? What is the common site you get a stricture?
In palpation,
You have to lift the scrotum and the posterior and the perineal region, you have to palpate through that. So now,
Yes,
you, what is Buschke-Lowenstein tumor?
it's a verrucous carcinoma of penis, sir. It's a locally invasive and destructive form of carcinoma of penis. It's not, there is no lymph node or system spread for the disease, sir.
But it is called condyloma lata or acuminata?
Condyloma acuminata, sir.
What is condyloma lata?
It's a syphilitic, secondary syphilitic.
So how will you differentiate these two? What will it looks like in the condyloma lata in a syphilis? So that is a very like a fleshy growth. This is a warty growth. What you are doing. Is there any difference between Buschke-Lowenstein tumor and the carcinoma penis? That is both can produce a viral disease. Any difference in the virus? Which virus causes that?
Human papilloma virus causes.
The same strain is causing it, or it is a different? What is the strain which causes the malignancy?
16 and 18, sir. HPV 16 and 18 causing malignancy, sir.
So the benign warts are caused not by 16 and 18, caused by
6 and 11. 6 and 11.
So the carcinoma penis, what is the relationship of the carcinoma penis and carcinoma cervix? Both are caused by the human papilloma virus 16 and 18.
Okay, yes, sir.
Is it a sexually transmittable disease?
No, sir. Carcinoma penis is not considered as sexually transmitted disease, sir.
How you are going to proceed on this?
What is BXO? Have you heard about BXO?
Sir,
BXO.
balanitis xerotica
Xerotica.
obliterans.
Balanitis xerotica obliterans. Okay, it is also one of the commonest penile conditions. Could it be malignant lesion, pre-malignant lesion, or not?
It is considered as pre-malignant lesions.
No. It is one of the DD for the differential diagnosis for pre-malignant conditions, but it is not a malignant condition. It's not a pre-malignant conditions. BXO. It actually is soft red velvety lesions over the more often over the previous. It looks like malignancy. It is not a pre-malignant conditions. BXO.
Okay, sir.
Yeah. Just please take out.
Now, how you are going to proceed?
Sir, for the confirmation of the diagnosis, we have to take edge-wedge biopsy from the lesion, sir. And for the and in this case, there was a
what you are going to expect in the biopsy? Histologically,
mostly it's a squamous cell carcinoma.
What type of carcinoma?
Squamous cell carcinoma.
What will be the finding of a squamous cell carcinoma in the What will be the finding in the histology?
Keratin pearls will be there, sir. Because of the presence of keratin pearls, we are classifying two grades, sir. High. Another features are
mandatory to have a keratin pearls?
No, sir. No,
can
sir.
you have a non-keratinizing?
Yes, sir. Non-keratinizing can also occur, sir.
No. Most of the time, it is when the papilloma virus is caused, it can be a non-keratinizing also. So you must stay with the breach in the epithelium, basement membrane, and this keratin pearl is usually that is indicated. So since you have made a diagnosis and you said your staging, something you said T1.
Yes, sir.
What is the staging you have put on?
T1, N1, M0, sir.
What is T1A?
T1A, there won't be any lymphovascular or perineural invasion. It's not a high-grade tumor, sir.
So what is TA?
TA, locally invasive squamous cell carcinoma of penis.
So having a TA is a very rare.
Non-invasive, no.
So where else in what carcinomas you get TA lesion? What other carcinoma you can have a TA lesion? Because normally when we say, well, say so transitional cell carcinoma of the TA bladder, and that staging also you get a TA. But otherwise, most of the carcinoma you don't have the TA staging. It's always T1, TX, T situ in situ, and then here you get that. So suppose there is a. How do you know there is a lymphovascular invasion is there or not? Clinically, can you make it out?
Clinically, we can't make it out, sir. Only biopsy we can.
Biopsy. Any other way? It's a clinical
In
examination.
MRI.
What precautions you take when you're taking MRI?
We have to induce artificial erections, sir.
So the position of the penis should be in an erectile position to take that stuff. So having made a diagnosis, and how will you? What are the options you have? And how are you planning that? So this is.
You said biopsy of the penis. Anything else you would like to do?
Sir, there's a right side mobile lymph node. We have to take FNAC from the lymph node, sir. Plus, if it is negative, and other investigations like USG of the penis, USG abdomen and pelvis to rule out lymph node involvement, sir. An MRI of the penis, sir. These are the investigation I'm planning to take for the patient, sir.
We would do a CT scan. Okay.
Yeah,
would you do a CT scan?
Yes, sir. For
of what area, of what region, and why?
CT abdomen, we have to take CT scan, sir.
Yes, correct.
And
why? Why?
Iliac nodes, sir.
Which
Iliac
node?
nodes.
Iliac
nodes.
Any other nodes?
In other, in CA and in
Can
CT,
you get some
abdomen,
node? You can some node directly going from the glans penis.
cloacat nodes. Glance directly to cloacat.
This is the groin.
Groin. You can pick it up in the inguinal area only. The terminal apex of the femoral triangle, you will get it. That you will get on ultrasound. CT of the abdomen, which nodes you want to look for, which group of nodes, because that is going to change your management. Iliac is correct. After that?
Para-aortic and periaortic nodes.
Do you want to look at the para-aortic? Aortocaval and para-aortic, you want to look at those nodes?
Carcinoma.
Most
common carcinomas, sir.
Yeah. If it is going to the aortic, para-aortic nodes, how will it change your management? See, the natural station is inguinal to superficial to deep, then to iliac obturator, then may go to the para-aortic.
Yes,
if your para-aortic nodes are involved, then how does it change your management?
Are you going to do any surgery?
The disease will become inoperable. No, sir, inoperable. The disease will become going to inoperable stage, sir.
You will go for what then?
So
incurable.
Yeah.
In inoperable conditions, neoadjuvant concurrent chemotherapy can be along with circumcision. We'll go for concurrent chemotherapy.
In this patient, circumcision, madam, already done, no? What will you do in this patient?
Initially, dorsal slit examination was done, sir.
You are not done a circumcision?
No, sir.
Okay, fine. But there's a growth, right, in the picture, like proper growth. Like, what is the extent? It is extending how much into the shaft from the glans? How much?
Clinically 1 centimeter proximal to the coronal circle, sir.
1 centimeter to the
shaft.
Okay. So shaft. How much? What surgery you will do?
For this case, I will go for.
How will you address this case only? How will you address the primary? And then what is your next step after that?
Maximum organ sparing, partial amputation of the penis.
This patient. Okay, you want to spare the organ in this patient. You want to spare the penis. So what surgery you will do? Number
partial
one.
amputation.
Partial. Is it possible to do it? It is possible to do in this patient.
Yes, sir.
So how do you decide which patient goes for partial penectomy? Which patient goes for a total penectomy? How do you decide?
Will the remaining functional penis, depending upon the functional penis, sir.
Yes.
Remaining functional.
That stump, how much?
At least 2 centimeter. If there is at least 2 centimeter, we can go for partial penectomy, sir. If less than 2 centimeter, we'll go.
Is penectomy always done, or we can, irrespective of the stage, penectomy should it be done irrespective of the stage?
Yeah, irrespective of the stage. Sir, for T1 up to TIS and TA, we can go for initial stages. We can go for we can avoid penectomy, sir.
What will you do?
Other modalities treatment for topical therapies available, wide local excision, glandectomy, most microscopic operation. All these options are available for initial stage.
Let us say there is a carcinoma penis involving the shaft. You are not able to provide the 2 centimeter stump. There are paraotic nodes.
Now the condition is inoperable, sir. So chemotherapy and radiotherapy.
Always the penectomy is always a part, some address to the primary is always a part of the treatment. Okay. Otherwise it will infect, right? It's an area which can get infected very easily, even which is infected always. So even if it is a stage 4 disease or a, advanced, you have to remove the primary in carcinoma penis. What you do next depends on the stage. Okay. All those surgeries which you told, any one of them you can do based on the indication. Or you told a list of surgeries, glandectomy, partial excision, all those you can do, whatever, total penectomy. What you do next depends on the stage. Okay. So what do you do next after the main primary is addressed? What is the next part of the surgery?
It depends upon the nodal status.
This patient, your patient.
If the FNAC is positive for malignancy, we'll go for
so if FNAC is not possible for malignancy, you won't do anything.
No, sir. We have to give a course of antibiotic and redo the FNAC, sir. If it's still negative, we can go for prophylactic inguinal lymph node dissection. Sir.
You already have a node, madam.
Yes, sir. So in case we have to do bilateral inguinal lymph node dissection. Sir.
Prophylactic lymphadenectomy means what?
No, if there is no node palpable, for high-grade tumors, we can go for prophylactic.
Now the treatment of CF penis depends on how you are going to address the lymph nodes, inguinal nodes, isn't it?
Okay.
And the iliac nodes. So some form of treatment should be given, whether it is palpable or not palpable. If it is not palpable or on an antibiotics it disappears, what you're going to do? If it is proven malignancy, what you're going to do? Step by step you go. Let us say the lymph nodes are not palpable or they disappear after the course of antibiotics. What you wanted to do. Your FNAC, which you did in the beginning, is inconclusive. How will you proceed?
Sorry. Excisional biopsy have to taken from the.
Have you heard of something
or
called?
we can the dynamic sentinel lymph node dissection.
What is dynamic sentinel node DSNB? What is that? Dynamic sentinel node biopsy. What is it?
Sir, in the with the use of USG.
Not USG. We are going to inject a first
gamma probe. Dye and technetium.
Correct.
With
You're on the
the
right
help of
path.
gamma probe.
You are going to inject a sulfur colloid based methylene blue, as well as you are going to use a radionuclear tracer, technetium 99. Then you are going to next day use the
Gamma probe detector.
and then take out the lymph nodes which are taken up the dye and send them for biopsy.
Dyes.
Yeah, send them for biopsy.
Yes.
So which is the node, which is the commonest node which is involved in sentinel node for CAPNS?
Most common is Cabana node.
Yeah, what is
Cabana
that?
node, sir.
Like, tell me like anatomical name of that Cabanas node. It's not written, no, there, Cabanas node. Where, how will I search?
Where exactly it is situated? Anatomically.
Junction of GSV and femoral vein, sir. It's promedial to the junction of GSV and
Exactly.
Okay. So,
Ashwati, in your examination, you mentioned of the digital examination, per rectal examination. What is the need to do the per rectal examination in this case?
Sir, secondaries from prostate is a possibility in CAPN.
No, that is not the answer. Probably if there is a blockade to the routine group of lymph nodes, there could be retrograde spread. In that cases, the deep pelvic lymph nodes could have been involved. That can be made out with the per rectal examinations. Yeah. Then the retrograde spread, it can occur to the deep pudendal group of lymph nodes that can be palpated through the rectal examination. That can happen in advanced carcinoma. Okay. Because the routine group of lymph nodes are blocked. Then it's possible.
Yes.
So, doctor, you have done your, let's say the lymph nodes are palpable. Okay. Like in your case, you're able to hear, your screen is frozen. You're able to hear me?
Yes, sir, I'm able to hear. Sir.
Let us say your patient, this lymph node is, what is palpable is malignancy. It is N1 only. How will you proceed now?
N1 only, sir.
N1.
We will proceed with FNAC from the node, sir.
No, I told you, no, it is proven to be on FNAC. How will you proceed?
Proven positive.
Which one?
Okay, sir. Proven positive, sir.
Your patient investigated, FNAC is antibiotics given, FNAC is squamous cell carcinoma from the penis.
Okay, sir.
Okay, proceed from now.
Bilateral inguinal lymph node dissection.
What will you do on the other side is not palpable, no? Only one side.
Before inguinal lymph node dissection, we have to give neoadjuvant chemotherapy, sir.
No, you are debating. There is no need to do any operable for that lesion. Probably there is no role for the neoadjuvant chemotherapy. So you can address the primary as well as the secondary if there is a N1 group of lymph nodes. When there are no nodes on the opposite side, you can wait and watch. There is no indication of prophylactic lymph node dissection on the opposite side. The side which is involved, which is the N1, you can go with the superficial inguinal block dissection. Okay. Then at the same time, you have to look for the iliac lymph node status. Many times you need to go for ilio-inguinal group of lymph nodes.
Okay, sir.
Okay, that all depends upon if the multiple lymph nodes are in the groin becomes positive or a frozen section, there could be fair chances of involvement of the inguinal iliac group of lymph nodes. That is the case, you have to go for the ilio-inguinal group of lymph node dissections. There is no role of prophylactic on the opposite side, invariably.
Okay, sir.
Doctor, what I will do is superficial and deep radical inguinal lymphadenectomy on the side which you are palpating the node. Okay.
Okay, sir.
Now, if one side there are positive nodes, then the next station is the iliac. Correct?
Yes, sir.
So,
yes, sir.
Which side was involved? Right side, right?
Yes, sir.
So, you are going to do a right side ilio-inguinal block dissection. Radical means both superficial and deep you have to take out. Correct?
Okay, sir.
Now, the controversy is what to do on the opposite side. Opposite side, you can just do the superficial inguinal lymphadenectomy. Do not do the iliac. Send the superficial for frozen. Okay.
Positive.
If it comes positive, then do same what you have done on the Left side.
Sims, opposite side.
But these are all very morbid procedures. Okay. If your iliac group of lymph nodes is involved, then you're in the realm of non-curable. Means it is palliative, whatever you're going to do. Okay. Right.
Okay. Okay.
Can you tell me the extent of anatomical extent of lymph node dissection in the groin? How far you need to clear? Anatomical boundaries of inguinal group of lymph nodes. That is a thigh.
Superiorly, it's inguinal ligament from ASIS to pubic tubercle, and 25 centimeter from the ASIS, 15 centimeter from the pubic tubercle, and imaginary. We have to clear.
Everything will not go on the dimensions. You are right. Anatomical extent. How far you need to go there?
Laterally sartorius and medially adductor longus, sir.
Very good,
And,
very good. Medially up to the lateral border of the adductor triangulus, and laterally from the sartorius and apex of the femoral triangle. All fat, fascia, and lymphatics up to the deep fascia of the thigh needs to be taken up. Okay. So, what is the extent of iliac lymph node dissections?
So, medially urinary bladder, laterally obturator nerve, sir.
Yes.
Superiorly the bifurcation, the common extend and then iliac bifurcation, and below the obturator foramens.
Very good, very good. This is the extent of an iliac group of lymph node dissections. Fine. Go ahead.
Thanks.
So what to do if the inguinal nodes, when you have done a radical inguinal, ilioinguinal, the iliac nodes are negative, but superficial what are positive and the deep are negative. What will you do next for this patient? What is the next role of management?
Shall we consider surveillance for this case, sir?
So which patient you will give chemotherapy, which patient you will go for surveillance? Surveillance is when it's N0 and you are dissected both sides. It is N0, right? Both sides. And it is proven on dissection to be N0. There are no micromets. Those don't go for surveillance. This side is positively done. Superficial is positive for malignancy.
Only superficial
Deep is negative. This is iliac are negative. What you will do next? So, is there any role for adjuvant chemo? Short answer, no. No, it doesn't make a difference. Okay. For our level, MS level, I think this much discussion is enough. But probably urologists have many ways of treating. I hope if there's any urologist here, they may make things clearer. But they have many advances. They will treat for the sake of treating because they have to offer something better than us. So exam, no, simple, I will tell you, simple literature to follow are the ESMO guidelines. ESMO, ESMO. Don't go reading Campbell and all those books. Take ESMO, European Surgical Onco Guidelines. You open that. It is in the app also, you'll get it. It gives a nice table on how you have to manage carcinoma penis. And it updates itself. Whenever ESMO updates their guidelines, that also will update. Okay. Don't read NCCN. Don't read the Campbell. Read the Campbell, the theory part of it. Okay. Whatever you said, glanzectomy, all that is from Campbell, you read, right? I'm sure it is given there only. But for treatment, no, simplify. You go for the ESMO guidelines. They're given in a nice table. Okay. CAPN is very difficult case to get actually in the exam because there's a lot of controversy in the inguinal lymph node management. Okay.
Most of the time you will not get. It is not a very common case.
Yeah, it's not very common. Actually, it's common in our country, but yes, in the West it is called as an orphan disease because nobody wants to do research on it because it's rare. So there's not much literature available. The guidelines, no, if you look at it, there'll be a lot of different guidelines because they don't do those trials. Okay. Anyway, good presentation. So how much you answered, like your knowledge of DSNB and all is good. That you should know. Okay. What is Drexler's quadrangle?
So
Have you heard
superficial
of
inguinal dissection.
modified inguinal dissection? Modified inguinal dissection. You don't dissect the entire quadrangle. Okay. This is when it is N0. N0, when it is N0, you don't have sentinel node biopsy facility. You are going to do limited dissection between the saphenous vein and the adductor. That area you are going to do, adductor magnus. You're not going to do the entire quadrangle where you normally do, right? If that comes positive, you do the next surgery. Okay.
What is the mode of death on these patients? Most of the time.
Most due to the erosion of lymph, torrential bleeding on femoral or main vessels due to the erosion of the lymph nodes. It's a main cause of death.
Okay, and these are the malignancies which have got more morbidity rather than the mortality. So the mode of death invariably erosion of the vessels. But we have not seen. So though much written in the literatures is not quite as often as seen in the practical side. Similarly, the carotid blowout, which commonly occurs following the radical neck dissection, this is also more described in the literature more often, but you do not see much. But it is common standard questions asked in the exams. What could be the mode in case of carcinoma penis, and what would be the long-term complications, immediate complications of radical neck dissections?
So what I've seen, CA penises die of renal failure.
How to cover these vessels? Have you got any idea about this? When you've done the dissection, lymph node dissection, how are you going to?
Sartorial flaps to prevent the.
Yeah. Yes, you have to disconnect the sartorius from the anterior superior side, take it medially to cover the vessels and hitch it to the inguinal ligament. Okay. What is the prognosis of this N1 diseases or in advanced diseases? 5-year survival in carcinoma penis?
95% survival.
For T1 diseases?
Yes,
for T3?
For N1, 70% survival.
Okay, for T1, N1, and M0, probably it is more than 70 to 80%. Whereas for T2, N1, or T3, it drops down to around 30 to 40%, the 5-year survival.
You know, what are the various types of incision for the inguinal block dissection?
Sir.
Can you hear me?
Yes, sir.
Are you able to? Just asking, what are the various types of incisions? I'm not audible.
Sir.
Hello.
Oh, what are the question is not clear, sir.
What are the various types of incisions which you can make for the inguinal block dissection?
S-shaped.
It is fine if you don't know better. Even I don't know.
You're very lazy people. That's why.
Dr. Kanagavel, I think we
can you
should
tell
proceed.
various ways to prevent the flap necrosis, which is a very
Thank you very much. Ashwati, do you have any questions?
No, sir.
Thank you very much.
Good presentation.
Yeah, great, good presentation, beta. Good.
Thank
I
you,
think
sir.
we should leave.
Thanks.
Thank you, Dr. Kanagavel, for the opportunity.
Thank you, sir. Thank you for the opportunity, sir.
He's relieved.
Thank you, faculty. Thank you for contributing this evening. And I look forward for more contributions in the near future. Srinivas Spicer and Apur sir, and I could have see a lot of other faculty. Ishwar sir has joined, Kushantapa sir has been
Very actively, yeah.
And thank you, sir. Thank you for joining this evening. Thank you, students, Ashwati and Kishore. Thanks for joining in a short notice. Thank you very much.
Thank you, Kanagavel, sir. Thank you very much.
Thank you, sir.
Good night.
Sir, with the permission, I will call this session a close, sir.
Okay. Thank you, sir.
Thank you, sir. Thank you very much.